Hello, this is Dr. Tan. I've been posting about mini BipolEP. This is a case of a 62-year-old male with acute urinary retention. His prostate size is about 120 cc with a normal PSA. Upon cystoscopy, you can see that there's a lot of trabeculations and sacios that are noted, and you can also actually see some pus cells around the area, around within the bladder. So anyway, to begin, I usually use a Collins knife as markers for my initial incision. So after I do my formal cystoscopy, I would change the cutting loop into a Collins knife, and then do the procedure that I need, or the markers that I need to put in. So a lot of us have been looking for what is really the gold standard for benign prostatic enlargement surgeries, but bipolar energy has been there for a very long time, and actually the first procedure of enucleation was done using a monopolar energy. So I think a lot of urologists would be more familiar using a resectoscope when doing when you're about to do any benign prostatic surgery. So I guess this is something that we can be familiar with, and maybe hopefully the learning curve with this one is easier. However, there are some publications that would say that it's a little bit harder to do enucleation with a bipolar resectoscope. So here we begin. I always put a marker in the sides of the vero, so it's like an omega incision again, trying to preserve some tissue beyond the veromontanum. So this is my first marker. So with this one, I'm using the settings of my bipolar cautery is at 90 for cutting, and 60 for coagulation. So with this part, as you can see, I'm marking the my initial borders for doing the enucleation. So it's like an omega incision, just similar to that of laser enucleation with prostate. And of course, I'll try to do apical release incision. This one is somewhat similar to that of Dr. Muhammad Omar from Egypt, doing the incision, putting a deep incision between the junction of the prostate and the sphincters. So I put in a lot of mucosa to just save up the mucosa, so that there will be more chance, or easier for the sphincter part to heal during the healing period or recovery after enucleation. So what's good about this, you have to incise deeply just to be able to release what you need to release during this procedure. So once you're able to do the markings, I would deepen my incision on the lateral side of the lateral lobes, trying to look for the plane between the prostate or prostatic capsule and the gland. So once I'm sure with the space, I try to push it a little, give a little nudge, just to make sure that I'm in the right plane. And also at the same time, before I change my loop, usually I would change it into a cutting loop. I make sure first that I have found a plane. Now, after I change a loop, I begin somewhat a mechanical dissection of the prostate. And then as well as while doing it, I would control bleeders and do some cutting. So you can see the arteries here being coagulated. So yeah, the difference between the bipolar and the laser is usually it's easier. I mean, it's faster to coagulate. However, it's something that you'd be afraid of when using a cutting or bipolar loop would be the depth of the cut. Usually it would cause some problems. So, or you might be able to perforate the capsule when you're not really sure of what you're cutting. So this one, it's obvious. We can see the difference between the plane of the capsule and the prostate. So this one would be my around, it's a 1 o'clock or 12 o'clock incision, and controlling the bleeders along the way as I do some blunt dissection. So this one, I will be releasing the prostate, the apex of the prostate from the sphincter, from the anterior part of the sphincter. So gently and slowly, being very careful. So usually even when doing laser prostatectomy, I would slow down in this part just to be more careful and more accurate in incising whichever I need to incise to get into the right plane and to be able to release the prostate. So yeah, so this one would give us, a better understanding of what are we really trying to remove. And based on this one, you can see that we are able to release the actual gland from the sphincter already, from the mucosa on the sphincter. There you go. And we are pushing it gently, and with a little bit of traction, with a little bit of push, you help it with the cutting loop. So it's just like you're doing a TURP. However, it's in a retrograde manner of cutting. So it's like you're pushing the gland with the loop. So with a similar technique as I do in laser prostatectomy, I cut through the 12 o'clock. I try my best to put down the gland from the anterior part, from the capsule and the anterior part. So once I'm able to put down the gland, I will try to dissect it going down towards the equator. The equator would be the junction between the bladder neck, the bladder floor, and the gland. So this part, you can see you have to be very careful not to cut too deep because it's already the capsule behind that prostatic gland. So yeah, so right now we're trying to release the anterior part. So yeah, I learned this technique from Professor Muhammad Omar. I saw one of his video and tried to mimic what he was doing, but also as well putting in my technique with it, combining my technique with it, and releasing the anterior part first, and not doing any trying avoid to doing perforation. If you can see, I was able to identify the curtain into the bladder neck before we cut it. And yeah, so right now we're trying to control the bleeders from the bladder neck. And yes, this is the bladder neck. So again, this is the part that I'm talking about, that I'm trying to push down the anterior part of the lateral lobes, gently pushing it down towards the bladder floor, so I will be able to free it already from the anterior part of the capsule and the sides of the prostatic capsule. So once I'm done, so I will proceed with going to the other side, the lateral lobe, but I will release the distal part of the median lobe first, just to connect two sides. Okay, so once I'm able to do it, I'll be releasing the lateral lobe, the right one. So again, similar, saving the mucosa from the anterior part of the sphincter, so as not to cause any damage to the urethral sphincters. So yeah, so this procedure is actually very nice, and I think it would be good for those urologists who doesn't have any laser in their practice or in their hospital, so they can start trying to do enucleation of the prostate, and using the bipolar resectoscope. Please comment down below if you think this is a good option for doing enucleation of the prostate, compared if you don't have a laser, a holmium or a thulium or a thulium fiber laser. So yeah, so it's the same procedure, same thing that I was doing in the other side, and trying to save some mucosa from so not to damage the sphincters. So I'm just connecting what I was able to incise already from the other side, from the left side. Now completing the part that I have to put down the gland from the right side. So yeah. So far, actually, what I noticed is I would have less chances of transient stress incontinence with this one, although I am using mini BipolEP. This is a French 19 and 22 resectoscope, bipolar resectoscope. If you want to know where I got it, I'll tell you in the comments later, so you'll be able to contact the guy who gave it to me. So yeah, anyway, so we're almost done, or releasing the anterior part of the right lobe, and like previously, we were able to see the curtain that we usually see, like this one, when we are already at the bladder neck. Now again, controlling the bleeders, putting down the gland towards the equator, just not to be careful enough not to perforate or destroy the bladder neck of the patient. So yeah, so it's somewhat very familiar, because we were all trained doing transurethral resection of the prostate. So the use of the loop and the strength of how the loop cuts maybe it would be very familiar for us. I don't know if you think this would be easier to learn compared to that of using the laser. However, I learned doing laser prostatectomy by myself actually, and watching a lot of videos, and actually I started with the vapor section. So anyway, again, so when I try to dissect the prostate away from the capsule, especially in the medial part, I what I do is I just push it up, not forward. Push the gland up towards the bladder neck. So you are expecting that the prostate is not really it will not fall on a straight line or a straight path when dissecting the posterior part. It would be most likely going up, because the prostate is a sphere. So contrary to the most TURP cases, you would see that the prostate would be flat. So this one, you are going to get the full gland from the posterior part, and try to use the cutting loop to release the addition, the sticky part, where there would be hard to do a blunt dissection. So we're almost there. We're already at the part of the bladder neck, releasing on each side whatever we need to release. We're lucky that this prostate is not really too adherent to the capsule, so we're able to show a good dissection, and that's why I wanted to upload this and show everyone that it's doable. You can use a cutting loop doing the bipolar resectoscope. Well, I think it would be better to say that enucleation is still enucleation regardless of the energy that you're using. And I guess the part that we should be talking about is not the energy being used for doing the enucleation, but more of the process of enucleation that we are doing, and avoiding all the possible complications related to it. So here you've seen that I was able to remove the prostate gland already from the bladder neck and the prostatic fossa, and right now we're trying to control the bleeders. When I control the bleeders, I usually look at the neck first, and then move distally as I can see when there's bleeding. And one good thing about doing a BipolEP is it's either that you use a morcellator, and if you do not have a morcellator, you can actually use your cutting loop to cut. So this one, I'm gonna be using a resectoscope, a morcelloscope later, and do a morcellation of the gland that I was able to enucleate. So yeah, so right now we're trying to just control the bleeders. Do take time to control whatever was bleeding, and you can see in the few seconds in the video that we did preserve the sphincter very well. So right now we're just trying to control whatever was causing the redness, the bleeding within the prostatic fossa. So this is the part that I do like about the bipolar cautery. You can actually do a good control or coagulation, even if it's large vessel because of its depth. The energy, the transfer of energy is quite deeper compared to that of the laser, and you'll be able to coagulate more area compared to that of the laser. So yeah, so just continue. Do take time to coagulate because it will really help you. It will not give you too much pressure when you're gonna do the morcellation. So take your time, maybe 5-10 minutes doing the control of bleeders, making sure that you're okay, and double checking your capsule for perforations, sinuses if there would be, and controlling them using the cutting. So do try to avoid putting coagulation or cutting or putting energy in the bubbles. Comment below if you have experienced any popping sound or like a burst of the bubble when you're doing the when you were able to do cutting or coagulation within the bubble. And this actually I was not able to experience it, but I have some friends who were able to experience that. However, the problem is it perforated the bladder, so they had to open up. So yeah, so be careful when doing that. So yeah, so we are able to control some of the bleeders, and I think yes, there are blood clots in the bladder. So maybe the suction, the morcellator can be, or will be able to suck it out. Yeah, so I'm using a Jaws morcellator from Hawk. I think it's okay. It's very controllable. I'm able to this is the one that I'm really familiar with. Although I have tried different morcellator scope. I have tried the Cyberblade. I have tried the Piranha. Cyberblade is actually okay also, but it really depends on the strength of your suction machine. There will be recommended suction machine along with that Cyberblade. However, with Hawk, it's one system similar to that of the Piranha, and of course it's more affordable. And yeah, so I think it's one thing that you have to be very familiar with doing morcellation. So yeah, so sometimes I notice with the saline solution, the water would be a little bit more murky or like blurred. I don't know if it's really just the scope, but it's more of the sometimes when I try to just irrigate some more, and yeah, I will be able to see the tissue very well. And when I do the morcellation, normally I would make sure that the bladder is always distended, and yeah, so you have to find the sweet spot or the cycles per minute that you like. And if there is some like hard or the beach ball nodules, I would recommend